morning or good afternoon, everyone. I am so glad you are here joining us for our next edition of our disease education webinar series. This is going to be a fantastic topic today. The title of our talk is Demystifying the Role of Palliative Care in Pulmonary Fibrosis. And our speaker today is Dr. Anna Gersten. Dr. Gersten is a pulmonary and critical care specialist at Johns Hopkins Hospital, and she's also currently in fellowship training in hospice and palliative medicine. And she has a special interest in interstitial lung disease, and is planning to start a multidisciplinary breathlessness and supportive care clinical initiative at the end of her fellowship that's aimed to improve the quality of life for patients with advanced lung disease. So she is really just a perfect person to talk with us today about this really important topic. I have a couple of notes before we get started. If you would like to ask any questions, we will have time at the end to try to field as many of those as we can. Please remember that we cannot dispense personal medical advice on our webinars here. So do try to keep your questions topical as much as possible. You can submit questions by going to your control panel on your screen and clicking the little arrow next to questions and type your questions there. If you are interested, the slides are available for download on the handout tab on your control panel. And if you have any trouble during the webinar, just drop us a chat in the chat box there, and we'll try to help you out if we are able to. So without any more, oh, one last thing, I'm so sorry. At the end of our session today, please just pause and stay with us for just a moment. There will be an opportunity for some survey feedback there, and we value your feedback and would like for you to take that opportunity to let us know how you thought the session goes today, and if there's something we can work on in the future, and that will help us develop our series as we go forward. So that was the last thing I was going to say, and let me just welcome again Dr. Anna Gersten. Thank you so much for being here.
Thank you so much for having me. It's a true honor to be here, and I thank you to all of you for taking the time to join today. So this is me. The title of the webinar today is Demystifying the Role of Palliative Care in Pulmonary Fibrosis. And what I hope to share with you today is an idea of what is palliative care, how can palliative care help people with pulmonary fibrosis, when is the best time to ask for palliative care support, and how can I learn more about palliative care? I have no disclosures to report. The medical disclaimer for all of the webinars, I'll just give you a few seconds just to read through it. Okay, so the first question I wanted to help address is, what is palliative care? Well, the word palliative actually originated from the Latin word pallium, which literally means to cloak. And the idea of palliative care is really to cloak you and your family with added support. Palliative care is specialized medical care for people living with serious illness. It's care that's focused on providing relief from the symptoms and stress of a serious illness. And the goal is to improve quality of life for both you as the patient and your family. And I wanted to quickly draw attention to this little icon that you can see at the top right-hand side of the screen that says CAPC. So you'll see as a reference on many of the slides that I'll be sharing with you today. A lot of this really great information comes from the Center to Advance Palliative Care. It is an organization built out of Mount Sinai with really the goal of advancing palliative care and educating both providers and patients on what is palliative care. So you may have heard a few different terms kind of thrown around. Sometimes we say palliative care, sometimes we say supportive care, sometimes quality of life care. They all mean the exact same thing, and the goals of all of these different types of service care is really to help you live better. So there are different ways to present the domains of palliative care. In my mind, I wanted to share with you kind of my view of the 4 main domains. So the first big domain is symptom management, and that includes physical, psychologic symptoms and helping you to really address those symptoms and feel better. You know, we certainly always want to recognize that serious illness also deeply affects someone's family. And so it's critical that we have a support service to really help care for those that are helping to support the patient in addition to the patient. And so caregiver support is really a key domain of palliative care. Certainly social support is key. You know, we want to do everything we can to minimize social isolation, to get you all of the community resources possible. And then spiritual support is something that is often, unfortunately, unrecognized. And, you know, in palliative care, we really believe that it's key to address someone's spiritual needs in addition to all of the other needs. So I just wanted to share with you, if you do see, you know, a palliative care team, what members of the team might you meet? So very often there's a physician, there's oftentimes a nurse practitioner or sometimes a physician assistant. We'll oftentimes have a registered nurse as a part of the team, a social worker, a chaplain, a pharmacist. For patients with pulmonary fibrosis, we really like to include a respiratory therapist in the palliative care team, as well as a physical therapist and sometimes an occupational therapist as well. In general, all of these members of the interdisciplinary team really work together to kind of meet your needs based off of those 4 main palliative care domains that we saw on the prior slide. So where can I receive palliative care services? Well, thankfully, we have a lot of different options. There's home-based palliative care. There are palliative care services in the hospital, in outpatient clinics. There are teams of palliative care providers that service nursing homes and assisted living facilities. And there's a lot of recent initiatives actually aimed to bring palliative care services to dialysis centers to kind of help with patients that require a lot of time spent at a dialysis center. And the nice thing about receiving palliative care in so many different settings is it really enables continuity of care and really close collaboration between the different members of the interdisciplinary team. So I wanted to share with you the 3 main types of palliative care, and I created a pyramid diagram for you just to show that the bulk of palliative care that we have is actually primary palliative care. And then as we kind of move up on this pyramid, you'll see an increasing level of expertise in palliative care, but a lower number of providers who are able to kind of provide that level of palliative care. And so primary palliative care is palliative care that's provided by your ILD specialist or maybe your primary care doctor. Secondary palliative care is provided by a palliative care provider with specialized training in the field. They will usually be board certified. Tertiary palliative care is provided by a palliative care specialist at a tertiary medical center. And what that means is it's also synonymous with an academic medical center or a medical center that can cater to very high acuity patients. And most of the PFF care centers that we have are considered tertiary medical centers. So I wanted to share with you this idea of concurrent care, and we'll explore this a bit more further. But many of you have, good relationships with your primary care provider, your pulmonologist or ILD specialist, and ideally, we could add to this a palliative care provider. And I wanted to show you all of these intersecting circles because there is so much collaborative care where when we put our specialties together, we can really take the best care of you. And the other part that I wanted to show you in this particular diagram is encompassing all of these different types of medical care is actually community support. And that means your family, that means maybe a religious community, friends, potentially therapists or other members of the community that are really helping to support you. And at the center of all of this is really you and your family. So what are the benefits of palliative care? Number one is really to help relieve symptoms. Once again, those symptoms can be physical, psychological, spiritual. Palliative care can really help both you and your family understand to the best of our ability what to expect moving forward. And in doing so, it can help both you and your family try to prepare for the future. And I will say this many times during this presentation, but really one of the key aspects of palliative care is to help support caregivers and family members and make this as supportive of a general experience as possible for everyone involved in, your care. What we see with palliative care involvement is that people feel a little bit more empowered and in control. And so even when, you might feel like you can't catch your breath or this cough just won't go away, we see decreased crises because oftentimes we have kind of symptom management plans, or if you look and your oxygen saturation is less than 90% and you're worried, here's what we can do so that once again, we're not in a crisis mode where you or your family needs to call 911, rush you over to the emergency room. And really what we want to try to minimize is hospitalizations. So we're going to move into kind of what we know from some of the research studies that have been done in palliative care. And the first study that I'll share with you is really a monumental study in the world of palliative care, and one of the first what we call randomized controlled trials, or kind of best level of research that we're able to do. And so in this particular trial, Jennifer Temmel enrolled patients who had metastatic non-small cell lung cancer, and they were put into two different groups. One group received standard care, and the other group received early palliative care, which was very novel at the time this study was done. And what we saw was improvement in quality of life and mood in the group of patients that had received early palliative care. And the shocking part of this study was that we actually saw increased survival by about 2 months in patients who received early palliative care. And I'll just show you that here graphically on the right-hand side. And what we can see is that the percentage of patients that are surviving is actually higher with that red line in the group of patients that received early palliative care, as opposed to the blue line, which is the group of patients that received standard care, which unfortunately did not include palliative care. And this was really a landmark trial that ended up in one of the highest impact journals that we have in medicine, called the New England Journal of Medicine. And so what do we know about palliative care in people with lung disease? So this was a trial that was done And what we did is created a breathlessness support service and took patients with many different types of advanced lung disease, including pulmonary fibrosis. And patients were divided into two groups. They either received standard care that did not include this breathlessness support service, or they received a breathlessness support service that included palliative care. And what we saw was that patients reported increased mastery of their own breathlessness within one of the questionnaires that's commonly used in this type of research. And so basically, patients who received this breathlessness support service felt more empowered to be able to handle and tackle their own breathlessness as a symptom. And interestingly, in this study, we also saw increased survival, and this is in both the subgroups of patients, those with COPD, as well as those with interstitial lung disease. And I'll show you again, just kind of graphically, you can see once again that red line is the patients who received this palliative care support service, and we had higher survival as opposed to those patients with the blue line who did not receive this extra layer of supportive care. And so what do we know about palliative care in interstitial lung disease? Well, Mina Kaluri, who actually is in Canada, really kind of pioneered a lot of the initial research that was done in this kind of arena. And so what she did was change the clinic model for all of her patients with interstitial lung disease and added palliative care as part of the routine care. And then she looked at how care changed once they had the addition of this palliative care support service. And what she saw was increased rates of advanced care planning, which is really just synonymous with patients and their families being able to prepare for the future. She saw a decrease in the number of emergency room visits and hospitalizations, which once again, we want to decrease those moments of crisis, and we really want to empower you and your loved ones to not need to rush over to the emergency room, to be able to go through kind of a plan and then decide on the next phase of care if needed. And what we saw with this palliative care involvement is that more people chose to remain at home rather than go to the hospital. And this was the preference of those patients. And so, you know, what we can extrapolate is that we were able to really, you know, help those patients achieve those preset goals that had been discussed with the palliative care service. And so the Pulmonary Fibrosis Foundation recently completed a survey, and they surveyed providers at all 68 PFF care centers, trying to elicit what provider perspectives are on palliative care. And what we found is that 67% of providers working at PFF care centers do report referring their patients to palliative care. 80% of the providers who do report referring their patients to palliative care do so at symptomatic progression. And actually only 2% of respondents who do report referring their patients to palliative care do so at the initial ILD or pulmonary fibrosis diagnosis. And this is not something that right now we have enough information to really know when is the best time to refer, you know, patients with pulmonary fibrosis to palliative care. And so this survey was helpful for us to understand kind of current practice patterns as we in the pulmonary fibrosis world are trying to determine what recommendations really should be. And 66% of respondents who said that they rarely refer their patients to palliative care cited lack of local palliative care availability as a reason for not referring their patients to palliative care. And then 95% of the ILD providers did report that they believe it's important to address advanced directives, which once again is helping you all and your families to really prepare for the future and feel a little bit more like you're kind of at the reins of your own care. And so I wanted to share with you in creation of the survey, we use that information to actually write 2 Pulmonary Fibrosis Foundation statements on palliative care. One is designed specifically for patients and their families, and then the other one is actually designed for providers, just so that the PFF could provide a little bit of more guidance on kind of what seems reasonable in terms of palliative care involvement for the pulmonary fibrosis, population. And what I wanted to really highlight here is we were really lucky to have help from Darlene Cochran as well as Mike Henderson, 2 really fierce patient representatives and advocates who really helped us along the way to understand a bit more, what is the patient perspective? How can we serve you the best? Because ultimately, that's kind of what everyone's goal is. And so I wanted to share with you this particular graph, and you'll see this a lot in some of my future slides. What the question I'm hoping to try to help answer is, when do we start thinking of palliative care? And historically, maybe 15 years ago, we would say, let's try to do all disease-directed therapies until we don't have any disease-directed therapies left to try. And then at the very, very end of life, that's when we would have palliative care involvement. And the main, what we call governing bodies within the pulmonary world, and what I mean by that are the American Thoracic Society, the American College of Chest Physicians, really began to write about and publish guidelines saying that, that is not the correct way to think about palliative care. And instead, we should follow a little bit more of the notion that as disease-directed therapies may decrease or become less available, that's the time to ramp up palliative care. But there's almost always a role for palliative care, even at the initial diagnosis. And what you can see here is that as people require more care, and that occurs over time, in general, we want to ramp up palliative care involvement, but that doesn't necessarily mean that we would take away any disease-directed therapies, as long as those are tolerable, certainly for the patient. And at the very, very end, where we have a substantial amount of palliative care involvement, that may be the time to consider adding hospice as an extra kind of layer of support. I do want to clarify, because I think this gets very confusing, that palliative care is not synonymous with hospice care. Hospice care is a small subset of palliative care. And so palliative care is something that's appropriate for someone at any age and at any stage of serious illness. Whereas hospice it's a model of palliative care, but it's really meant to be delivered, more towards the end of life. And so I made you a little bit of a table here just because I think it still is a bit confusing what's the difference between palliative care and hospice. But I think a nice way to think about this is that in general, palliative care is really just based off of your need, the need of your family. It's absolutely given concurrently with other disease treatments. It's appropriate at any stage of serious illness. The payment model is similar to the way that you would see a cardiologist or a nephrologist. It's this fee-for-service kind of provider billing system. And thankfully, palliative care is widely available in hospitals. There is a limited, but thankfully now growing outpatient kind of palliative care arena. And in contrast, hospice is really a service that's designed to kind of help at the end of life. And there's a lot of nuances that have to do with insurance here that I'm happy to answer questions on if anyone has them later, but the gist of it is that if you reach a point in your illness where it seems like hospice may be appropriate, in general, we would move away from those kind of disease-directed therapies and more towards all of your care being really directed towards enhancing and improving quality of life. And hospice is technically an insurance benefit. It is covered 100% by all insurances, including Medicare and all of the other private payers as well. And hospice is widely available in both community as well as institutional settings. And I promise we won't dwell too much on hospice during this particular presentation, but I did want to share with you that I think there's a very common misperception that hospice is a scary, negative place, and if you decide that you want to enroll in hospice, that there is hope that's taken away. And I just wanted to spend this one slide with you really sharing that I don't believe that's actually the case at all. Having spent a large chunk of time over the past couple years in a hospice setting, I actually believe that hospice carries a lot of hope with it. And so what I show you here is even within the word hospice, we can see hope. And when we decide to utilize a hospice benefit, there's a lot of really nice things that come along with it. So for those of us that are really close to pets, if you decide to utilize hospice support, you can either be home with your pets, or a lot of the hospice facilities are very open to having pets there too. And I think there's probably there are few things as therapeutic as having your own pet with you. And your family just can be instrumental. I think, unfortunately, the COVID pandemic has really decreased visitation in all sorts of medical settings, and hospice has really worked towards keeping visitation as open as possible, or if you get to be home, then just being with your family and having that layer of support. Food is very important to many of us, and I think one of the beautiful things about hospice is whether you're home or potentially in a hospice facility, the food tends to be delicious, and you are able to bring in the most comforting foods from home, or if you are home, your family is able to cook for you those things that you really enjoy. I have also gotten to spend a fair amount of time with a lot of the hospice providers that see patients in the home, and I just think those relationships are so beautiful. And hospice always tries to make sure that there's a lot of continuity in care, so that the nurses that are visiting you are the same nurse every week, the aides are the same aides, and I think that there's really beautiful relationships that form because of that continuity. in general, it's really nice to be either in the comfort of your own garden or in a lot of the hospice facilities. They have beautiful gardens. You know, here in Baltimore, one of our local hospices really made a point out of making sure that there was a balcony present for every patient's room in the hospice facilities, and that balcony actually can accommodate a full hospital bed. So it's just a really beautiful experience to be able to, you know, have quality of life really optimized as much as possible, be within nature. And so I wanted to share with you a sample patient, and we'll walk through with him as we go through more of the slides. So this is Joseph. He has a new diagnosis of pulmonary fibrosis. He was just told that he needs to start wearing oxygen. He is feeling a bit overwhelmed, just isn't quite sure what this pulmonary fibrosis means. And because of all this uncertainty, he's having a lot of worries about the future. Symptomatically, he's feeling quite short of breath. He has this cough that doesn't seem to go away. He's feeling pretty tired, anxious, and a little bit depressed. And I really like this particular diagram because I think it's so important in patients like Joseph and maybe like you too, that at the center of everything, we want you to have a good quality of life. And we have all of these interconnected wheels that contribute to this central wheel of quality of life. And if we aren't helping to control all of these other symptoms, we aren't able to give you a good quality of life. And so I think this is a nice diagram that just highlights in particular how important it is to address all of the many facets that contribute to quality of life. And now I'll introduce you to Jessica. She's been married to Joseph for 50 years. She's really been struggling with her husband's diagnosis. She also shares a lot of uncertainty about the future. She wants to be as supportive as is humanly possible. And she heard about something called palliative care that could potentially help her and her husband. And so when I return to this graph, I wanted to show you kind of where Joseph is right now. So he's just received his diagnosis. Thankfully, you know, he's not at a place where he has some symptoms, but he's not terribly burdened by symptoms. We're not sure what kind of disease-directed therapies he has available. He certainly would benefit from palliative care. And that leads to the question that many of you all might have, which is, how do I ask my doctor about a referral to palliative care? So what I encourage you to do is really share your symptoms and ask how the symptoms can be treated. Share your worries and ask who else might be able to help provide support to you and your family. And I would directly ask if a palliative care referral would be helpful for you. And I always encourage people to really, really advocate for this extra layer of support, even if your doctor is reluctant. How can you find a local palliative care provider? So there is the National Hospice and Palliative Care Organization has a really nice website where you just plug in a zip code. And if you have a specific provider that you're looking for by name, you can. Otherwise, it'll give you a nice list of palliative care providers in your area. Get Palliative Care, which is associated with the CAPC organization, but is more patient-centered, has a beautiful search tool where you can put in your zip code and then you can say, I'm looking for a palliative care provider in a hospital setting, a nursing home setting, an office or clinic setting, or a home-based setting. And I've had a lot of patients find this particular search tool very helpful. So moving back to Joseph, so he did ask his doctor about a referral to palliative care. He found a local palliative care provider using one of those websites. He did start disease-directed therapy. He started an nintedanib for his pulmonary fibrosis. His symptoms are being addressed by palliative care. And here we see he's kind of, moving along over time with his diagnosis of pulmonary fibrosis, but certainly receiving a nice mix of disease-directed therapies and palliative care. And this is another nice figure that was published in particular for patients with pulmonary fibrosis. And I like the way that it demonstrates the different ways that we can provide supportive care to you all. And so I think certainly supportive measures oftentimes include supplemental oxygen, pulmonary rehabilitation, education, which you all are here at this webinar today, so clearly value. Certainly psychological support is so important. And part of supportive care is disease modifying treatment, making sure that if antifibrotic therapies or immunomodulator therapies are appropriate for you, that we make sure that you receive those therapies. Certainly if there are clinical trials that would be appropriate for you, helping to make sure that we get you into those trials. Symptom relief, once again, making sure that we get the breathlessness under control, try to help you to minimize the fatigue, the cough, and then certainly help to treat any anxiety and depression. And then another bucket of comprehensive supportive care is, making sure that we at least think a little bit about end-of-life care, do what we can to kind of help you prepare for the future. And now we go back to Joseph, who's unfortunately hospitalized. He unfortunately needs the breathing tube connected to the breathing machine. He is awake for a lot of this and just feels very uncomfortable. He does get treated for a pulmonary fibrosis exacerbation. He is able to have that breathing tube safely removed, but he really decides this is not something that I want to go through again. So he has progressed within his disease course, and we can see where he is now. He may benefit from actually more palliative care involvement and less disease-directed therapies. So he continues to see palliative care. He kind of shares with them how frustrated he is about weakness from the hospitalization, not being able to golf like he used to. Thankfully, his palliative care provider teaches him some strategies for energy conservation, so he's able to get out on the golf course again. His symptoms are well controlled. Jessica's feeling supported. And he begins to think, maybe hospice is something I would be interested in. So, when do I qualify for hospice? So you would qualify for hospice if you have a serious lung condition with severe shortness of breath at rest, known progression of your lung condition over time, plus the need for oxygen support continuously at rest. And I don't want to scare anyone, because you can certainly need oxygen and not be ready for hospice in any way. But when we think about ways that we work with the insurance to make sure that they cover hospice support, these are kind of the two main criteria that we really look for. And so where's Joseph now? So, he feels like his symptoms are well managed, but he's kind of decided that he's not really interested in going back to the hospital. He doesn't want that breathing tube again, and he really, really wants to optimize quality of life. And so this would be a really good time for Joseph to think about hospice. And that's exactly what he does. He talks to his pulmonologist and his family, and he ultimately decides to enroll in hospice. He gets to be home with his wife and his grandchildren. Nurses come to visit him weekly in his home. His symptoms are very well controlled. And Jessica's able to make Joseph his favorite meals, which is really some of their favorite memories. So here we see, so Joseph is in the right place to be in hospice. He's receiving all of the supportive care that he needs. So how can palliative care, help me most? Certainly symptom management. I've mentioned this so many times, but I just think it's so critical to you feeling better and being able to have the quality of life that you deserve. Support for both you and your family. Helping you and your family to prepare for the future. And please remember, palliative care is not giving up. It's really helping you to live as well as possible throughout the course of your serious illness. Going back to just the root of the word, palliative care is really intended to cloak you with extra support and help you through these really difficult times. So how can I learn more? I think, reading the palliative care position statements that are available on the PFF website are really helpful. I would certainly start with maybe the patient directed position statement, and then potentially, if you're interested, certainly you could check out the provider one as well. I think this getpalliativecare.org website, once again, that's run through CAPC, is really helpful. They give a lot of nice information and some helpful videos, and this is all information that's really directed towards patients and their families. Caringinfo.org is another nice kind of wealth of information on palliative care, and this is really run through the PMO, which is the National Hospice and Palliative Medicine Organization, and this is kind of their patient-centered website. Another website that I think can be very helpful, especially if you and your family are maybe thinking about planning for the future, is prepareforyourcare.org. It once again kind of really nicely goes through some choices about your care. And I am now happy to open it up to questions, and just wanted to thank you all so much for being here today and listening to me speak.
Anna, thank you so much. This has been a wonderful presentation, just so much great information for our community here, and I hope everybody's taken a lot home from this. We do have some questions I thought I might field for you, so I'm going to toss a question that I had during the talk up for you first, and that was regarding the Higginson publication that you mentioned. What were the elements of the breathlessness support service in that particular study? How did they structure that, and what did that include?
Sure. Thank you so much. It's a really good question. So this was actually done on the inpatient side. So all of the patients that received this breathlessness support service were hospitalized. And what they had was they had a dedicated palliative care provider, a dedicated respiratory therapist, and a dedicated physical therapist. And they would come see the patient and then teach them about strategies to help with breathlessness, which not only helped the patients to feel less kind of dyspneic or less breathless, but it also, really importantly helped them to feel kind of more in control of this really awful symptom to feel.
That's great. Thank you. One question that came up was, what would it, if you were to be seen in, let's say, a specialty palliative care environment, clinic or home visit or something like that, what would that assessment be like? What would a person experience? Would there be testing, more talking, exam, things like that?
Sure, that's a really good question. So in general, the idea is really when you come to a specialty palliative care visit to, number one, try to understand kind of what your needs are, how we can best serve you. And then number two, to try to really understand how burdensome symptoms are for you, since that's something that is, I'll say, relatively easy to treat. And so oftentimes, when you come in, we will ask you kind of some standardized questions about your quality of life and about specific symptoms. And then what we do is we kind of brainstorm some strategies to help treat those symptoms. And then we may ask you those same questions the next time we see you, and again in the future, to try to see whether our interventions are helping you or whether we kind of need to regroup and try something else.
That's great. Yeah, that's helpful. And so I guess what I'm envisioning there is, if we're explaining to our audience here, is that most of that is sort of assessing how a person is feeling and less focused on, what our pulmonary function tests show and what our oxygen saturations are doing and things like that. Many times in my clinic, when I ask somebody how they're doing, they tell me, "Will you tell me?" and then ask me to look at their lung function test. Or when I ask how short of breath they are, they report their oxygen saturations. And so this is a little bit of a different answer to that question.
Yes, absolutely. And I think hopefully that might be refreshing to some of you, to not have us necessarily kind of go through all of your CAT scans and pulmonary function testing, but really just sit and listen to you and listen to your family and just check in and see how you're doing.
Absolutely. I have another interesting question. In the example that you provided, you shared about a patient and a caregiver. And we do have a lot of emphasis and support for our caregivers at through the foundation. There's there's this support group specifically for caregivers and some resources there. But in this case, the patient had a reliable family member caregiver. But are there ways in which palliative care might help and support a person who doesn't have as strong a caregiver as Joseph had and Jessica?
Yes, absolutely. Thank you for that question. I think that's where it's so important for us to have an interdisciplinary palliative care team, so that we can have, a social worker with true expertise in this area to really help, try to navigate what resources are available, what types of support groups may exist, virtually or in the community, what types of assistance programs might there be to help you if you're not feeling particularly well, to get food into the home, to make sure that you have all of the medications that you need. And so I think that social work is really integral here to help make sure that, we as a medical community get you tied into all of those kind of umbrella community resources that we can, think of or know of, to try to make sure that you feel as supported as possible. Because I think, we all hope that we each have a Jessica, but, oftentimes we don't. And so I think in palliative care, we certainly recognize that and want to make sure that we cloak you with that extra community support as much as possible.
That's fantastic. And I mean, it just highlights how valuable our caregivers are to our patients, but also that there are resources out there that hopefully our medical team can help bring people in contact with and get them set up with, that can help bridge some of those gaps. Okay, so I have a couple of questions sort of along the same lines. So you did talk a bit about hospice and how it's sort of it comes into play at a time when we will then step away from life prolonging therapies, for example. and you mentioned that palliative care can exist alongside most of those other therapies. So are there any treatment options or therapies or programs that you could not do while receiving palliative care services, such as pulmonary rehabilitation or even consideration for a lung transplant?
Great question. So whenever we're talking about palliative care services, it is just like you seeing a cardiologist. So it would have no impact on insurance coverage for pulmonary rehab or all of the testing you would need for a lung transplant. You just think of it as it's another medical subspecialist that I'm being referred to, and that will be covered by insurance. I will say, gets a little bit trickier when we talk about hospice support, because then we utilize the hospice insurance benefit. I will say that I have been successful in finagling things around and doing a lot of physician-to-physician communication with insurance companies to work very hard to make sure that patients don't feel like their other care is being taken away by choosing to enroll in hospice. So that can be a little bit tricky, but is definitely not an insurmountable barrier.
Yeah, I've run into some of that in the specific hospice setting where the pulmonary rehab, for example, becomes a bit more challenging in that scenario. If that's the admitting diagnosis and not something else. So that's but thank you for that answer. That's really helpful. Let's see, let me go back to my question box here. There was a question about ways to know or choose, if you have choice in your environment, a palliative care specialty provider that might be more familiar with pulmonary fibrosis.
Excellent question. So this is something that may be tricky for you to necessarily go on either of those websites I had shared with you and see kind of, oh, I see this person is a palliative care provider, but what is their experience with pulmonary fibrosis? I would recommend a few things. So number one, it never hurts to actually call that provider's office and say, hey, I have pulmonary fibrosis. I'm really interested in seeing a palliative care specialist. Is this a condition that your clinic often sees? I think would be really helpful. I will say that one of the big challenges that we face when we want palliative care providers for people with lung disease is that I will say most palliative care providers are heavily trained to help with different cancers, but not necessarily different lung diseases. Another tip that might be helpful is if you do have a pulmonologist or someone within your pulmonary fibrosis clinic that has some kind of knowledge about palliative care, to ask them, because oftentimes there will be kind of a specific clinic that they oftentimes have their patients go to. And then even if maybe that palliative care provider didn't start off very knowledgeable about pulmonary fibrosis, they certainly will learn through seeing patients over time and might be a really good fit for you. I will say that, you know, what we're all hoping for in the wave of the future is that, you know, you will be able to find a palliative care provider that really specializes in your underlying illness so that you can really get the most targeted palliative care. And I think we're taking steps towards that goal, but I don't think we're there yet. And so I think, you know, doing whatever research you can before, you know, you make the trek out to that palliative care provider's clinic, if let's say you're going in person, would be really helpful. And most of the time, there's a way to get that information before you actually see the person.
That's great advice. I have, so our outpatient palliative care options are fairly limited where I am. And so I have often suggested that when patients meet either a hospice provider or a palliative care provider for the first time, kind of conduct that almost like a job interview and see what they're, what do you think might help me? What do you think you could help me with? What do you think your services could do for me and my family and my loved ones, and make my life better? And think about it in those terms, particularly in those areas where there may be some limitations and options because of the limited but growing outpatient availability of palliative care. Until what time we have, many more options available to us. I have time for one, maybe two more questions, so I'll go ahead and ask this one quickly. What advice would you give to caregivers or family members about when and how to address palliative care for their loved one with pulmonary fibrosis? First, with the patient, if the caregiver is seeing maybe there's a need, but the patient may not necessarily have internalized that or thought of it, with their pulmonary fibrosis specialist physician, and then also with the primary care doctor.
Yeah, that's a really good question. So I have found that oftentimes in this kind of scenario where maybe the caregiver really feels like an added layer of support would be helpful for the patient, but maybe the patient just hasn't quite gotten there yet, is really to have kind of a straightforward conversation. And sometimes it's helpful to bring your pulmonary fibrosis provider into the mix and maybe kind of use them a bit as a sounding board to help say, I think this would be an added support that you would really benefit from. Same exact, thought process with primary care, especially because many of you all may be very close to your primary care providers and have very longitudinal relationships. I think it can be really helpful for the caregiver to just kind of express a bit of concern and worry and see if the patient is then open to the idea of scheduling an initial visit with palliative care. I will say that, the feedback that I've received after kind of helping to encourage patients to come see me in palliative care clinic is, oh goodness, that wasn't as scary as I thought, or that was nothing like what I thought it would be. And so I think it can be really nice just to kind of take that initial step to get into the door. And I have found in general that, caregivers are just so deeply attuned to the needs of their loved ones that, their opinion matters so much. And I've found, mostly that patients have really been open to that when that's been very clearly expressed.
That's fantastic. Yeah, that's super helpful. I think even as listening to you speak as a pulmonologist who sees pulmonary fibrosis patients every day, I think it is kind of challenging to know when and how to make that introduction, given all of the other things that we try to cover and educate about in clinic. And I think the more we're able to do from an educational standpoint and a socializing standpoint at the PFF or within our clinics and things like that, understanding what is palliative care, making it less scary, making it a palatable palliative option for people, and integrating that into the standard of care as Dr. Kalluri has done, really, I think eases that, and it makes it less transition and more just part of standard care, which I think is just so important for everybody. And we need to, I think, work really hard to get to that. And this has been a really great conversation, a wonderful presentation. We have so many questions, I can't get to all of them, but we will try to follow up with everybody by email if we haven't been able to answer your question today. Several people have asked if this webinar will be posted, and yes, it absolutely will. It will probably take a few days to a couple of weeks, but it will go up on our website and on our YouTube page and be available for review later. And while I'm talking, would you mind popping back in the slide deck to the list of resources there? I've had a couple of people ask for those. And for those people who are looking for them and can't quite write them down quick enough or take a screenshot, they are in the handouts section on your control panel, so you can go there and download that, and that will have those listed in the slide deck there. But those are our resources. And if it's just a last comment, if you guys will please stay and give us your feedback via questionnaire survey, we would really appreciate it. Again, Dr. Gerson, thank you so much for your participation today. Thank you everybody for attending, and have a wonderful afternoon.